Imagine this scenario. A 65-year-old man, he's got diabetes, chronic kidney disease, his creatinine's already up at 2.2, and his blood pressure, way too high, 176 over 92, even though he's on 5 different meds.
Tough case.
Right. He's been on furosemide, a strong loop diuretic, 80 milligrams twice a day for a year, still has some shortness of breath, some swelling. So his doctor adds another common diuretic, hydrochlorothiazide, 25 milligrams daily.
Okay, a combination therapy.
Exactly. 2 weeks later, he lands in the emergency room. Blood pressure's plummeted to 91 over 58. He's lost a shocking 15 kilograms, that's over 30 pounds, and his creatinine, it's skyrocketed to 10.8.
Wow, a dramatic decline.
So what on earth happened? And more importantly, how could that have been avoided?
Well, that case really cuts to the heart of what we're tackling today. It vividly shows the incredible power and potential pitfalls of the drugs we're diving into.
Absolutely. Welcome to a deep dive into diuretic agents. Now, when we talk diuretics, you might just think drugs that make you pee more. But it's so much more complex than that.
Oh, definitely. These are sophisticated pharmacological tools. They interact with your kidneys in incredibly precise ways, and they are absolutely fundamental for managing some of the most common and critical clinical disorders out there.
Our mission today is really to master this intricate topic, to go as deep as we possibly can. We want to unpack the mechanisms, the nuances, the clinical wisdom that defines how these drugs work.
Exactly. We're drawing heavily from a top-tier resource, KATZUNG's Basic and Clinical Pharmacology 16th edition, aiming to give you the kind of insight that the truly elite professionals in this field possess.
Our goal is that you walk away not just informed, but genuinely well-versed, really understanding the intricate dance between renal physiology and diuretic pharmacology.
To get you there, we'll journey through the fundamental transport mechanisms in the kidney tubules, then dissect the detailed pharmacology of the major diuretic classes.
And finally, we'll look at their critical clinical applications, always circling back to connect the dots, including understanding what went wrong in that initial intriguing case study. So let's get started. First things first, let's nail down the language. These terms get thrown around, but precision matters here. When we say diuretic in the broadest sense, what are we talking about?
Diuretic is simply the umbrella term for any agent that increases overall urine volume. Simple as that.
Okay. But then you hear natriuretic. How's that different?
A natriuretic is more specific. It's an agent designed to increase renal sodium excretion. Now, because sodium generally cools water along with it, osmosis, almost all natriuretics also increase water excretion.
Ah, so that's why they often just get called diuretics anyway.
Exactly. The water follows the salt. Then you have aquaretics.
Right. I found that one particularly interesting. What's their specific action?
Aquaretics increase the excretion of solute-free water. Think about osmotic diuretics like mannitol or the newer antidiuretic hormone antagonists, the vaptins. Their main effect is on water movement itself.
But they still increase urine volume overall.
Yes, which is why they still correctly fall under that broad diuretic label, even though their mechanism is primarily about water, not salt.
And then there's this cutting-edge investigational class. Diuretics. That sounds new.
It is. Diuretics are fascinating. They specifically block urea transport in the kidney. This increases urine output and urea excretion, but, and this is the key point, without significantly increasing electrolyte excretion like sodium or potassium.
So they're technically a type of aquaretic, but focused on urea.
Precisely. Their specific target gives them their distinct name. You see, getting these definitions straight is really the first step to appreciating the different strategies these drugs use.
Absolutely. And to really grasp how these agents work their magic, we need to understand the kidney's own language, starting with the nephron, that microscopic filtering unit.
KATZUNG emphasizes how the nephron is beautifully divided, structurally and functionally, into different segments. Each part has a unique role, filtering, reabsorbing, secreting.
And we'll be focusing on how diuretics strategically target these specific segments.
Exactly. That's where the action happens. And while we're setting the scene, it's worth briefly mentioning the kidney's own internal messengers, the autocoids.
Like local hormones within the kidney?
Sort of. Locally produced compounds like adenosine, prostaglandins, urodilatin, they exert complex, subtle effects on kidney function and can actually influence how well diuretics work. We'll touch on that again later.
Okay, good point. Like the kidney's own internal regulatory network influencing the drugs we give. So with that foundation, let's truly dive into the kidney's plumbing, the renal tubule transport mechanisms. Starting at the very beginning, the proximal convoluted tubule, the PCT. KATZUNG calls it the kidney's bulk reabsorber.
And for good reason. It's the kidney's first massive cleanup crew. In a normal person, the PCT reabsorbs an enormous amount of the stuff that gets filtered. We're talking about 2/3 of the filtered sodium, 85% of sodium bicarbonate, 65% of potassium, 60% of water, and pretty much all the glucose and amino acids.
Wow, it really does the heavy lifting up front.
It sets the stage for everything else. And water reabsorption here is massive too. The PCT is highly permeable to water, both through specialized channels called aquaporin 1 or AQP1, and also between the cells via claudin 2.
And that high permeability keeps the fluid concentration steady inside the tubule.
Exactly. It maintains constant osmolality. But a really key diuretic target here is the reabsorption of sodium bicarbonate. How does that work, and why is it so important pharmacologically?
Tell us about that.
Okay, so bicarbonate reabsorption in the PCT is this intricate dance. It heavily relies on two main players, a transporter called NHE3, which swaps sodium for a proton, and crucially, an enzyme called carbonic anhydrase.
Ah, carbonic anhydrase. That rings a bell with diuretics.
It should. So NHE3 brings sodium into the cell and pushes a proton, H+, out into the tubule fluid. That proton combines with bicarbonate HCO3 to form carbonic acid, H2CO3. Then, bam, carbonic anhydrase steps in and rapidly converts that into CO2 and water.
Which can then be reabsorbed easily.
Right. CO2 diffuses into the cell, gets rehydrated back to carbonic acid by intracellular carbonic anhydrase, and then the proton is recycled for NHE3 while the bicarbonate gets transported out the other side of the cell into the bloodstream.
So the key insight for diuretics.
If you block that carbonic anhydrase enzyme, both the one in the tubule fluid and the one inside the cell, you effectively jam up the whole bicarbonate reabsorption pathway. Bicarbonate gets trapped in the tubule and excreted.
And that's exactly what drugs like acetazolamide do.
Precisely. They are carbonic anhydrase inhibitors. That's their mechanism.
Okay, that's clear. Now, let's shift to a more recent and frankly revolutionary development in the PCT, the sodium glucose cotransporter 2, SGLT2. These inhibitors started out for diabetes, but wow, the diuretic and other benefits have been surprising.
Absolutely game-changing. SGLT2 is the protein responsible for hauling back most of the filtered glucose in the PCT. The truly fascinating part is that when you inhibit SGLT2, you don't just block glucose reabsorption, you also significantly decrease sodium reabsorption because they're transported together.
So you get a double whammy.
Exactly. You get osmotic diuresis from the unreabsorbed glucose pulling water out, and you get true natriuresis from blocking sodium reabsorption. What's really reshaped treatment paradigms, though, is that by reducing total body sodium content, these SGLT2 inhibitors have proven incredibly effective in heart failure and chronic kidney disease.
Even independent of their glucose-lowering effect.
Yes. Their benefits extend far beyond just blood sugar control. They fundamentally changed how we approach those conditions.
And KATZUNG mentions a regulatory link, too, with angiotensin II.
That's right. Angiotensin II, a key player in blood pressure regulation, can actually induce the production of SGLT2.
So blocking the renin-angiotensin system, like with ACE inhibitors or ARBs, might indirectly reduce SGLT2 levels.
It suggests that, yeah, it's another layer of this incredibly complex renal regulatory network. We also need to mention the organic acid and base secretory systems also located in the proximal tubule.
Why are they important for diuretics?
They're crucial because they actively pump various organic acids, things like uric acid, NSAIDs, but very importantly, many diuretic drugs themselves into the tubular fluid. This secretion mechanism is key for getting these drugs to their actual site of action further down the nephron.
Okay, good point. Moving on from the PCT, we hit the loop of Renal. KATZUNG calls it the diluting powerhouse. Let's start with the thin descending limb.
Right. Here, water is passively pulled out of the tubule. Why? Because the surrounding tissue, the kidney's medulla, is incredibly salty, very hypertonic. That osmotic gradient just yanks water out.
And this is where osmotic diuretics like mannitol come in.
Exactly. Impermanent solutes like mannitol, things that can't be reabsorbed, stay inside the tubule. They counteract that osmotic pull, holding water in the tubule and preventing its extraction. That's their aquaretic activity.
Then there's the thin ascending limb.
Relatively water impermeable, but permeable to some solutes, not a major diuretic target. But the real action, especially for our most powerful diuretics, happens in the next segment. The thick ascending limb, or tedalo.
Okay, the TL. A major player, right? It actively reabsorbs a big chunk, maybe 15–25%, Of the filtered sodium chloride?
A very significant amount. But crucially, the TL is almost completely impermeable to water.
Which makes it a diluting segment.
Precisely. It actively pumps salt out of the tubular fluid, but water can't follow. So the fluid remaining in the tubule becomes more dilute and the salt pumped out. Especially in the deeper medullary parts of the TL, it helps create and maintain that salty medullary environment that's vital for the collecting duct to concentrate urine later on.
And this is where the loop of Hemel gets really unique, and where loop diuretics exert their massive effect. What's the key transporter here?
The star player here is the Na plus K plus 2-CLAL cotransporter, known as NKCC2. It sits in the luminal membrane facing the tubular fluid. This transporter is the specific selective target that loop diuretics block.
Okay, blocking NKCC2 stops salt reabsorption. But you mentioned something fascinating earlier about a lumen-positive electrical potential here and its effect on other minerals.
Ah, yes, this is a really elegant mechanism. So NKCC2 brings in sodium, potassium, and chloride, but some of that potassium leaks back out into the lumen through another channel called RMK. This outflow of positive charge, K+, creates a slight but significant positive electrical potential within the tubule lumen.
Like a tiny positive charge inside the tube.
Exactly. And what does a positive charge attract? Negatively charged ions. No, it repels other positive charges. But importantly, it provides the driving force for the passive reabsorption of other positive ions, namely magnesium, Mg2+, and calcium, Ca2+, pushing them between the cells via the paracellular pathway.
Ah. So when loop diuretics block NKCC2,
They disrupt the whole process. Less salt transport means less potassium recycling back into the lumen, which diminishes that lumen-positive potential. Without that positive driving force, the paracellular reabsorption of magnesium and calcium decreases significantly.
and that's why loop diuretics cause increased urinary excretion of magnesium and calcium alongside the sodium and chloride.
Precisely. It's a direct consequence of inhibiting NKCC2 and altering that electrical gradient. It's a key mechanism underlying some of their important side effects, like hypomagnesemia with chronic use.
Fascinating. Okay, from the loop, we move distally to the distal convoluted tubule, the DCT. It handles less salt, maybe around 10% of the filtered load.
Correct. Significantly less than the PCT or TTAL. And like the TL, it's relatively impermeable to water, so it contributes further to diluting the tubular fluid.
What's the main transport mechanism here?
The primary mechanism for NaCl transport in the DCT is an electrically neutral, thiazide-sensitive non-plus cold toe transporter, known simply as NCC.
NCC, and that's the direct target for...
Thiazide diuretics, like hydrochlorothiazide, clothalidone. They specifically block this NCC transporter.
Now, you mentioned calcium handling is different here compared to the TEL. No lumen-positive potential.
Right. No significant lumen-positive potential driving paracellular movement. Instead, in the DCT, calcium is actively reabsorbed through a different mechanism. It enters the cell via an apical calcium channel and is then transported out the base lateral side by a sodium-calcium exchanger.
And this process is regulated.
Yes, importantly, it's regulated by parathyroid hormone, PTH. This hormonal control is a critical piece of the puzzle for understanding how thiazides, which act here, uniquely affect calcium balance, something we'll definitely revisit.
Okay, great. Finally, we arrive at the end of the line, the collecting tubule system. This includes the connecting tubule, the collecting tubule proper, and the collecting duct. It only reabsorbs a small fraction of the filtered salt, maybe 2–5%.
A small percentage, yes, but don't let that fool you. This system plays an absolutely crucial role in the final determination of body fluid volume and the final concentration of sodium in the urine. It's the fine-tuning stage.
And this is where aldosterone really comes into play.
This is the primary site where mineralocorticoids, especially aldosterone, exert their most significant influence on sodium and potassium balance.
And critically, it's the main site for potassium secretion.
The most important site for potassium secretion by the kidney. And here's a key takeaway. Virtually all diuretic-induced changes in potassium balance originate from alterations in transport within this collecting tubule system.
So tell us about the principal cells here. They handle sodium, potassium, and water, but differently than other segments.
Very differently. Unlike the cotransporters we saw earlier, principal cells in the collecting tubule have separate, distinct ion channels for sodium, called NAC, and potassium, like ROM-MK and BK channels.
Separate channels. How does that change things?
It creates a unique electrical environment. Sodium entry through ENSC typically predominates over potassium secretion through its channels. This net influx of positive charge, NAC+, creates a significant lumen-negative electrical potential, typically between 10 and 50 millivolts negative inside the tubule compared to the cell.
A negative charge inside the lumen this time. What does that drive?
That negative potential does two things. It drives chloride, Cl reabsorption passively between the cells, paracellularly, following the electrical gradient, and crucially, it provides the electrical driving force that pulls positively charged potassium ions, K+, out of the principal cell through those apical potassium channels and into the tubular fluid for excretion.
Ah, and this directly links to potassium wasting with certain diuretics, doesn't it? If you deliver more sodium downstream.
Bingo! If upstream diuretics like loops or thiazides block sodium reabsorption earlier, more sodium reaches this collecting tubule system. That increased sodium delivery fuels more sodium entry through ENSC, which makes the lumen even more negative.
Enhancing the driving force for potassium secretion.
Exactly. It ramps up potassium loss. And it gets even worse if that extra sodium arrives with an anion that can't be easily reabsorbed, like bicarbonate coming from upstream carbonic anhydrase inhibition. That makes the lumen exceptionally negative, further accelerating potassium secretion.
So this increased sodium delivery, coupled with that enhanced negative potential, is the core reason for potassium wasting.
That, combined with the fact that the volume depletion caused by the diuretic often triggers the body to release more aldosterone. Aldosterone then acts right here on these principal cells to further ramp up sodium reabsorption and potassium secretion. It's a perfect storm for potassium loss. Understanding this mechanism is absolutely fundamental for managing patients on diuretics.
And aldosterone's direct role. How does it boost sodium reabsorption and potassium secretion?
Aldosterone is a steroid hormone. It works by increasing the number and activity of both the apical ENSC sodium channels and potassium channels, as well as the basolateral Na plus K plus ATPase pump, which provides the energy for the whole process. The net result is a dramatic increase in both sodium reabsorption and coupled potassium secretion.
What about the other cell type here, the intercalated cells?
Intercalated cells, which come in alpha and beta types, are primarily involved in acid-base balance. Alpha cells mainly secrete protons, H+, contributing to acid excretion, while beta cells secrete bicarbonate. They fine-tune the body's pH.
Okay. And finally, water concentration. This segment is where antidiuretic hormone, ADH, and aquaporins play their critical role.
That's right. Principal cells contain a specialized system of water channels called aquaportin 2, AQP2. The permeability of this segment to water is tightly controlled by antidiuretic hormone, ADH, which you might also hear called arginine vasopressin, or AVP.
How does ADH control it?
ADH binds to V2 receptors on the basolateral side of the principal cells. This triggers a signaling cascade, mediated by CAMP, that causes preformed vesicles containing AQP2 water channels to fuse with the apical membrane, inserting the channels and making the membrane permeable to water.
So no ADH means impermeable to water and dilute urine.
Correct. In the absence of ADH, the collecting tubule is like a brick wall to water, and you produce large volumes of dilute urine. When ADH is present, it dramatically increases water permeability, allowing water to be reabsorbed down its osmotic gradient into the hypertonic medulla, resulting in concentrated urine.
And ADH also affects urea transport.
Yes, it stimulates the insertion of a urea transporter, UT1, in the medullary collecting duct cells. This helps urea accumulate in the medulla, contributing to that high medullary osmolarity needed for maximum urine concentration.
Which brings us neatly to a specific class of diuretics.
The Vactins. These drugs are ADH antagonists. They block the action of ADH specifically at those V2 receptors in the kidney, thereby promoting the excretion of free water.
That's an incredibly detailed tour of the nephron's transport systems. Amazing complexity. Now let's briefly revisit those local modulators, the autocoids, starting with adenosine.
Right. Adenosine levels rise in the kidney during hypoxia or high energy consumption. Interestingly, and quite uniquely, in a hypoxic kidney, adenosine actually acts to decrease renal blood flow and glomerular filtration rate, or GFR.
Kind of a protective mechanism.
Possibly. It acts mainly via A1 receptors found on the afferent arteriole and various tubules. It influences ion transport and plays a key role in tubuloglomerular feedback, that system where the kidney senses salt delivery downstream and adjusts GFR accordingly.
And the diuretic link.
Adenosine receptor antagonists, drugs that block these A1 receptors, have been shown to inhibit NHE3 activity back in the PCT and do exhibit diuretic activity. What's really notable, though, is that unlike most other diuretics acting upstream of the collecting tubules, these adenosine antagonists generally do not appear to cause significant potassium wasting. That's a potential advantage.
Interesting. Okay, next up, prostaglandins.
Prostaglandins are major local players in the kidney. PGE2 in particular, acting through various receptors, plays a role relevant to diuretics. It tends to blunt sodium reabsorption in the thick ascending limb and also interferes with ADH-mediated water transport in the collecting tubules.
So these actions of PGE2 actually contribute to the effectiveness of loop diuretics.
They do, significantly. Which brings us back to a really important clinical interaction. What happens when a patient takes an NSAID, like ibuprofen?
They block prostaglandin synthesis.
Exactly. NSAIDs blunt cyclooxygenase activity, reducing prostaglandin synthesis. Therefore, they can interfere with loop diuretic activity, reducing their effectiveness. This is a common cause of diuretic resistance, especially in patients with conditions like nephrotic syndrome or cirrhosis, where renal prostaglandin production is particularly important. You absolutely need to be aware of this interaction.
Good point. What about natriuretic peptides?
We have ANP and BNP, mainly from the heart, and CNP from the brain. But the kidney itself makes urodilatin, structurally similar to AMP, right in the distal tubule cells.
And what does urodilatin do?
It blunts sodium reabsorption downstream in the collecting tubule system. It also tinkers with blood vessel tone in the glomerulus to increase GFR, adding to its natriuretic effect. Clinically, a recombinant form, ularitide, is being investigated for acute heart failure, showing some experimental promise, but neceritide, BNP, failed to show benefit in large trials.
And briefly, dopamine.
Produced elsewhere but has renal effects. Low-dose dopamine can increase urine output mainly by dilating renal arteries, but its overall role in treating fluid overload clinically is probably minor compared to standard diuretics. Phenoldiprem, a related drug, also has diuretic properties.
All right, we've laid a fantastic foundation understanding the kidney's intricate machinery. Now let's open the diuretic toolkit itself and examine the basic pharmacology, starting with the pioneers. Carbonic anhydrase inhibitors, CAIs.
Right, these go way back to 1937. They inhibit carbonic anhydrase, the enzyme we discussed earlier. While it's present in many places, its highest concentration and activity relevant to these drugs is in the proximal convoluted tubule.
So they block sodium bicarbonate reabsorption there. Acetazolamide is the main one.
Acetazolamide is the prototype, yes. They were really the precursors to all modern diuretics.
How do they behave in the body? Pharmacokinetically.
They're generally well absorbed when taken orally. You start seeing an effect, increased urine pH due to bicarbonate loss within about 30 minutes. The peak effect is around 2 hours, and the action lasts for roughly 12 hours. They get eliminated by being actively secreted into the proximal tubule fluid.
Which means?
You absolutely must reduce the dose in patients with renal insufficiency because their elimination depends on kidney function.
Okay. And pharmacodynamically?
Yeah.
Their effect on bicarbonate.
It's profound. They can depress bicarbonate reabsorption by up to 85% in the superficial PCT, maybe 45% across the whole kidney initially. This leads to significant bicarbonate loss in the urine and a very predictable hypercalcaemic metabolic acidosis.
And this limits their diuretic effect over time.
Critically. Because the body runs low on bicarbonate to filter, and because downstream segments compensate by reabsorbing more sodium chloride, the diuretic efficacy of CAIs drops off significantly after just 2 or 3 days of continuous use. The acidosis, however, persists as long as the drug is taken.
So while their use purely as diuretics is limited now, they have carved out other important clinical niches.
Absolutely. Their most common and arguably most important indication today is glaucoma. They reduce the formation of aqueous humor, the fluid inside the eye, by acting on the ciliary body. Topical versions like dorzolamide and brinzolamide lower eye pressure without causing systemic effects.
What about kidney stones?
They can be used for urinary alkalinization. Raising the urine pH can help dissolve or prevent certain types of stones, like cystine stones, but it's tricky. Prolonged use often requires adding oral bicarbonate, and paradoxically, the alkaline urine they create can actually make calcium phosphate stones more likely to form, potentially causing acute kidney injury. Acetazolamide itself can even crystallize in alkaline urine.
Okay. And metabolic alkalosis.
They can be useful, particularly when giving fluids volume replacement is risky, like in severe heart failure. Or if you need to rapidly correct the metabolic alkalosis that can develop after severe respiratory acidosis, they provide a modest extra diuresis too.
And they're standard for acute mountain sickness.
Yes, very effective. By increasing bicarbonate excretion, they help counteract the respiratory alkalosis that causes the symptoms. Even lower doses work well. They also have roles as adjuvant therapy in epilepsy, some forms of hypokalemic periodic paralysis, and can reduce cerebrospinal CSF production, useful for managing CSF leaks or idiopathic intracranial hypertension.
Other niche uses.
Increasing phosphate excretion in severe hyperphosphatemia, Meniere disease, sometimes nephrogenic diabetes insipidus, central sleep apnea, Klein-Levin syndrome, a fairly diverse list.
Now, toxicities. That hyperchloremic metabolic acidosis is expected?
Predictable, yes, and as we said, it's self-limiting for the diuretic effect, but persists pharmacologically. Renal stones are another risk due to the changes in urine composition. More phosphate, more calcium, less citrate, which normally helps keep things dissolved. Calcium phosphate especially precipitates easily in alkaline urine.
And potassium.
You almost always see renal potassium wasting. Why? Because that increased sodium delivered downstream, now accompanied by the poorly reabsorbed bicarbonate anion, makes the collecting duct lumen very negative, strongly driving potassium secretion. You often need to give potassium supplements or add a potassium-sparing diuretic. They also cause phosphorus wasting, potentially leading to hypophosphatemia.
Other side effects.
Drowsiness, paresthesias, tingling sensations are common, especially at higher doses. Nervous system toxicity can occur in renal failure, and hypersensitivity reactions, fever, rashes, bone marrow issues, interstitial nephritis, even the severe de-dress syndrome can happen, though rarely.
And a critical contraindication.
Definitely cirrhosis. In patients with liver cirrhosis, CAIs decrease the kidney's ability to excrete ammonium, NH4+. This can lead to hyperammonemia and precipitate or worsen hepatic encephalopathy, a major one to remember.
Okay, shifting gears to the modern era, SGLT2 inhibitors. KATZUNG calls them the modern glucose and sodium exporters.
A very apt description. This class includes drugs like dapagliflozin, canagliflozin, and empagliflozin. They work by inhibiting the sodium-glucose cotransporter 2, SGLT2, right there in the proximal tubule.
And SGLT2 normally reabsorbs most of the filtered glucose.
About 90% of it. So when you block SGLT2, you significantly decrease the reabsorption of both sodium and glucose. This leads to a substantial amount of glucose, maybe 30–50% of the filtered load being excreted in the urine.
How do they handle pharmacokinetically? Absorption, elimination.
They're rapidly absorbed after oral administration. Dapagliflozin, for example, has a half-life around 10–12 hours, mostly eliminated after metabolism. An important point. While the drug levels might be higher in patients with severe renal failure, the actual amount of glucose excreted in the urine declines as kidney function worsens. Dose adjustments are often needed.
And their use in kidney disease has evolved, right?
Hugely. Initially, they weren't recommended for severe renal or liver disease, but then came the major cardiovascular outcome trials, Ampero, Credence, DOPA-HF, DAPA-CKey. These studies included parents with GFRs down as low as 30 LMN, sometimes even lower, and showed not just safety, but profound benefit in these populations. It completely changed the game.
So their main indication now isn't just diabetes?
No. While they started as third-line diabetes drugs, their primary indication now is arguably their cardio and renoprotective effects. This is clearly established and has become the main reason for their use in many patients. They do lower HbA1c, typically by 0.5–1.0%.
What about other effects? Weight, blood pressure.
Yes, they typically lead to modest weight loss, averaging around 3.2 kilograms in some studies, partly due to the diuretic effect. And they lower systolic blood pressure by an average of about 5 mmHg. Studies clearly show increased urine volume, sodium, and potassium excretion upon starting them.
And that cardiorenal protection, how is it thought to work?
It likely stems from multiple factors. One key mechanism is reducing pressure within the glomerulus, similar to ACE inhibitors. Better blood pressure control plays a role too. Interestingly, they often cause a small initial dip in GFR when you start them, but this is followed by a significant slowing of the long-term progression of chronic kidney disease. This is considered a class effect.
And approved for heart failure, too.
Yes. Dapagliflozin and empagliflozin are approved for heart failure with reduced ejection fraction, even in patients without diabetes. They can increase urine output, reduce the need for higher diuretic doses in acute heart failure, often without significantly worsening measured renal function long-term, which is a major clinical advantage. Empagliflozin has even shown benefits in pulmonary hypertension.
What about adverse reactions we need to watch for?
There have been some reports of acute kidney injury, AKI, but it's still unclear how much is directly due to the drug versus its effects on fluid balance and blood pressure. The risk of hypoglycemia is very low when used alone or with metformin.
What about infections?
That's a notable one. There's about a 6-fold increased risk of genital fungal infections in women and a slightly higher rate of urinary tract infections overall compared to placebo.
And electrolytes.
Generally, they have minimal to no effect on serum electrolyte concentrations like potassium or magnesium, which is a significant advantage compared to many other diuretic classes.
Okay, moving on to the heavy hitters. The most potent mobilizers of fluid. Loop diuretics.
If you need to move a lot of fluid and move it fast, these are your go-to agents. Furosemide, bumetanide, torsemide, ethacrynic acid. They selectively inhibit NaCl reabsorption in the thick ascending limb, TAL, by blocking that NKCC2 cotransporter we talked about earlier.
And their potency comes from targeting that segment.
Yeah. Absolutely. The TL has a huge capacity for reabsorbing salt, maybe 15–25% of the filtered load. And unlike CAIs, their action isn't limited by acidosis. This combination, large capacity target and sustained action, makes loop diuretics the most efficacious diuretic agents we have, unmatched for rapid, large volume fluid removal.
Chemically, most are sulfonamides, except ethacrynic acid.
Correct. Furosemide, bumetanide, torsemide are sulfonamide derivatives. Ethacrynic acid is a phenoxyacetic acid derivative, which is important because it can be used in patients with a true sulfonamide allergy.
How do they handle kinetically?
Rapid absorption usually. Elimination varies. Furosemide mainly kidney, bumetanide mixed kidney-liver, torsemide mainly liver. Oral torsemide tends to be absorbed faster and more completely, more reliably than oral furosemide, which has notoriously variable bioavailability.
And duration of action.
Furosemide's effect lasts maybe 2–3 hours. Torsemide's is longer, 4–6 hours. Their half-lives are very dependent on renal function. And remember, their activity depends on getting secreted into the tubule by that proximal tubule organic acid transporter.
So NSAIDs can interfere.
Yes. NSAIDs and probenecid compete for that transporter, reducing loop diuretic secretion and thus their effectiveness. Torsemide also has an active metabolite, contributing to its longer action. While we have approximate equivalent doses, furosemide's variability makes direct comparisons tricky. Some studies hint that torsemide or bumetanide might lead to better outcomes in heart failure, maybe fewer hospitalizations or AKI episodes compared to furosemide, but a clear mortality benefit hasn't been proven.
Pharmacodynamically, we know they block NKCC2, reducing salt reabsorption and diminishing that lumen-positive potential. What does that do to divalent cations again?
It causes increased urinary excretion of both magnesium and calcium. Chronic use can definitely lead to hypomagnesemia, sometimes significantly. They generally don't cause hypercalcaemia, though, because the body compensates elsewhere, primarily via PTH action, but they can be used therapeutically to enhance calcium excretion in hypercalcaemia, but only if given with adequate saline hydration.
And prostaglandins are involved here, too.
Very much so. Loop diuretics actually induce the expression of COX2, leading to synthesis of prostaglandins like PGE2. PGE2 itself inhibits salt transport in the TEL, adding to the loop diuretics effect.
So again, NSAIDs are a problem.
A potentially significant problem. By blocking COX and reducing prostaglandins, NSAIDs can blunt the effectiveness of loop diuretics, particularly in patients really dependent on that prostaglandin component, like those with nephrotic syndrome or cirrhosis.
And they have direct vascular effects, sometimes even before the diuresis starts.
That's a fascinating observation. Furosemide increases renal blood flow, partly via prostaglandins. Both furosemide and ethacrynic acid can reduce pulmonary congestion and left ventricular filling pressures in acute heart failure, even before you see a big increase in urine output. This rapid preload reduction is thought to involve prostaglandin release and maybe direct effects on veins.
Clinically, their main role is in acute pulmonary edema.
Absolutely critical there. And for managing other significant oedematous states, heart failure, cirrhosis, renal disease, they are also effective antihypertensives, especially useful in patients with renal insufficiency, where thiazides might be less effective.
Other uses.
Treating electrolyte disorders like hypercalcaemia with saline and hyperkalemia. In acute renal failure, they can increase urine output, which might simplify fluid management, but importantly, they do not prevent or shorten the duration of the renal failure itself. They can sometimes worsen cast formation in myeloma kidney. They can also help accelerate the excretion of certain anion overdoses, bromide, fluoride, iodide, because these get reabsorbed in the TEL. Again, you need saline co-administration.
And that potential use for bumetanide in autism spectrum disorder.
Yes, that's an emerging area. Some recent studies and reports suggest bumetanide might be helpful, possibly related to altering chloride gradients in the brain. Early results show potential improvements in communication and cognition, but much more research is needed.
Okay, let's talk toxicity. Hypokalemic metabolic alkalosis is harm.
Very common. Directly related to that increased sodium delivery to the collecting duct, driving potassium and hydrogen ion secretion. It's dose-dependent and generally reversible with potassium replacement and correcting any volume depletion. Some data even suggest proactive potassium supplementation might improve survival.
Ototoxicity hearing loss.
Yes, that's a known risk. It's dose-related hearing loss, usually reversible. More common with very high doses, rapid IV infusion in renal impairment, or when used with other ototoxic drugs like aminoglycosides. It's thought to be due to inhibiting a similar NKCC transporter, NKCC1, in the inner ear.
What about gout?
They can cause hyperuricemia and precipitate gout attacks. This is mainly due to volume contraction enhancing uric acid reabsorption back in the proximal tubule. Using the lowest effective dose helps minimize this. Hypomagnesemia, as we discussed, is a predictable consequence of chronic use, especially with poor dietary intake. Oral magnesium supplements often cause diarrhea, complicating repletion.
And allergic reactions.
Since most are sulfonamides, except ethacrynic acid, you can see cross-reactivity. Skin rash, eosinophilia, rarely interstitial nephritis or de-dress syndrome. Ethacrynic acid is the option if a sulfa allergy is a concern.
Other potential problems.
Severe dehydration is always a risk with potent diuretics. Hyponatremia is less common than with thiazides. Loops often help prevent hyponatremia by impairing urine concentrating ability, but it can occur, especially with excessive water intake. Hypercalciuria, increased calcium in urine, is expected. While usually not causing low serum calcium, it can lead to secondary hyperparathyroidism over time. Paradoxically, in volume-depleted patients with an underlying tendency to hypercalcemia, like from malignancy, loops can actually unmask or worsen the hypercalcemia.
Any other rare toxicities?
May worsen thiamine deficiency and heart failure. Furosemide linked to a skin condition called pseudoporphyria. Chronic use might increase fracture risk. 4-bumetanide can cause injection site tenderness. Continuous infusion sometimes causes generalized muscle pain.
And contraindications.
True sulfonamide allergy, rare, is a contraindication for the sulfa-based loops. But the biggest danger is overzealous use, especially in fragile patients with cirrhosis, borderline renal failure, or severe heart failure, where rapid fluid shifts and electrolyte imbalances can be disastrous.
Okay, let's move to the workhorses of hypertension management and more. Thiazide diuretics.
Right. Discovered back in 1957, they were initially hoped to be stronger CAIs, but their main action was found to be inhibiting sodium chloride reabsorption in the distal convoluted tubule, DCT, by blocking that Na plus Cla cotransporter, NCC. Hydrochlorothiazide, HCTZ, is prototype. Some, like chlorthalidone, do retain significant CAI activity as well.
Chemically, they're all sulfonamides.
Yes, they all have an unsubstituted sulfonamide group. Almost all are taken orally. Chlorothiazide is the only IV formulation. HCTZ is more potent than chlorothiazide, used in lower doses. Chlorthalidone is a thiazide-like diuretic, absorbed slowly with a much longer duration of action. That's why it's often preferred for once-daily hypertension treatment. Indapamide is another thiazide-like drug, mostly cleared by the liver, but enough gets to the kidney to work.
And they all get secreted by that organic acid system in the PCT.
Yes, just like loop diuretics. And importantly, they compete with uric acid secretion there, which is why thiazides are notorious for increasing serum uric acid levels and potentially triggering gout.
Pharmacodynamically, they block NaCl reabsorption via NCC in the DCT. But the big difference compared to loops is calcium handling.
Absolutely critical difference. In stark contrast to loop diuretics, thiazides enhance calcium reabsorption.
How do they do that?
It seems to be a dual mechanism. Partly, the volume depletion they cause enhances passive calcium reabsorption back in the PCT. But more specifically in the DCT, by blocking NCC, they lower intracellular sodium, which increases the activity of the basilateral Na plus Se2 plus exchanger, effectively pulling more calcium out of the tubular fluid and into the blood.
So they don't usually cause hypercalcemia on their own.
Rarely. But they can readily unmask underlying hypercalcemia from other causes, like hyperparathyroidism or malignancy. This calcium-sparing effect is key.
Which has direct clinical applications.
Definitely. It's precisely why they are a mainstay for preventing calcium-containing kidney stones caused by idiopathic hypercalciuria. By reducing urinary calcium, they reduce stone formation risk. There's also some evidence they might modestly reduce the risk of osteoporotic fractures, likely due to this calcium retention.
And like loops, their action depends partly on prostaglandins. NSAIDs can interfere.
Yes, that interaction applies here too. NSAIDs can blunt the anti-hypertensive and diuretic effects of thiazides as well.
Clinically, their major indications are very well established.
Cornerstone for hypertension. Useful in mild heart failure. Essential for treating nephrolithiasis due to idiopathic hypercalciuria. And paradoxically effective in nephrogenic diabetes insipidus.
What about their toxicity profile? Hypokalemic metabolic alkalosis, similar to lupus.
Yes, the mechanism involving increased distal sodium delivery is similar. Risk seems highest in women, underweight people, and with long-term use over 5 years. They can also cause impaired carbohydrate tolerance, potentially worsening glucose control in diabetics or pre-diabetics, especially at higher doses like HCTZ 50 mg.
How do they worsen glucose control?
It's thought to be due to impaired insulin release from the pancreas and reduced glucose utilization in peripheral tissues. Hypokalemia exacerbates this, and correcting potassium can partially reverse it. They also have a weak off-target effect on ATP-sensitive potassium channels involved in insulin secretion. They can also cause a modest increase in total cholesterol and LDL levels, maybe 5–15%, though this may normalize over time.
And the one we need to be particularly vigilant about, hyponatremia.
Yes, hyponatremia is a really important and potentially dangerous side effect of thiazides. It's caused by a perfect storm. Volume depletion stimulates ADH release, they impair the kidney's ability to dilute urine, and they can increase thirst.
More common than with lupus.
Generally considered more common and potentially more severe than with loop diuretics. Elderly women seem most susceptible. That Swedish study finding thiazides responsible for a quarter of hospitalized hyponatremia cases is quite sobering. Careful monitoring, dose reduction, and limiting free water intake are key preventive measures.
And they're strongly linked to gout.
Yes, due to that competition for uric acid secretion we mentioned, they are probably the diuretic class most associated with gout precipitation.
Allergic reactions.
They are sulfonamides, so cross-reactivity is possible, though severe reactions are rare. Photosensitivity or generalized dermatitis can occur, extremely rare, but serious reactions include hemolytic anemia, thrombocytopenia, and acute necrotizing pancreatitis.
And that emerging concern about skin cancer.
Yes, there's accumulating evidence suggesting a link, particularly with long-term cumulative exposure for non-melanoma skin cancers, squamous cell, basal cell, and possibly melanoma, though the data there is more mixed. Bendroflumethiazide might carry a lower risk.
Other toxicities.
Weakness, fatigue, paresthesias are common. Impotence can occur, likely related to volume depletion. Rarely, acute angle closure glaucoma linked to hyponatremia, and hypomagnesemia, which is actually more likely with chronic thiazide use than with loop diuretics, especially after a year or more. Very rare things like drug-induced lupus, ARDS, Merkel cell carcinoma, choroidal effusion have been reported.
Contraindications.
Similar to lupus, excessive use is dangerous in cirrhosis, borderline renal failure, or heart failure due to the risk of severe electrolyte disturbances and volume depletion.
Okay, let's shift to the potassium-sparing diuretics. These agents are all about preventing potassium loss.
Exactly. They work in the collecting tubules to counteract potassium secretion, primarily by antagonizing the effects of aldosterone. There are two main mechanisms.
How are they?
First, you have the mineralocorticoid receptor antagonists, or MRAs. Spironolactone and eplerenone are the key players here. They directly block aldosterone from binding to its receptor.
And the second mechanism.
These are the sodium channel inhibitors, specifically amiloride and triamterene. They don't block aldosterone itself, but they directly inhibit sodium influx through that epithelial sodium channel, ENaC, on the luminal side of the collecting duct cells.
And since potassium secretion is coupled to sodium entry there.
Blocking sodium entry indirectly prevents potassium secretion. So they spare potassium too. And there's a newer investigational class, aldosterone synthase inhibitors, like baxdrostat, which block the production of aldosterone itself.
Let's look at the MRAs first. Spironolactone.
It's a synthetic steroid, a competitive aldosterone antagonist. Its effects last a long time because it's converted to active metabolites like canrenone with long half-lives. A key point about spironolactone is its structure allows it to bind significantly to other steroid receptors, notably the androgen receptor.
Which explains its side effects.
Exactly. That's why it can cause gynecomastia, breast enlargement in men, and decreased libido. Interestingly, it doesn't seem to increase breast cancer risk in women and can sometimes be used off-label for female pattern hair loss.
How does eplerenone differ?
Eplerenone is also an MRA, but it was designed to be much more selective for the mineralocorticoid receptor. It has several hundredfold less affinity for androgen and progesterone receptors compared to spironolactone.
Meaning fewer hormonal side
It's
effects.
considerably fewer. Much less risk of gynecomastia, for instance. It's generally considered as effective as spironolactone for indications like heart failure, but with a better side effect profile regarding hormonal effects. There's also an IV formulation called Kinreno.
And now we have newer, non-steroidal MRAs like finerenone.
Yes, finerenone, isaxarenone, epinephrine. These are newer agents. They work slightly differently at the receptor level and are also designed for high selectivity, avoiding androgen-progesterone receptor binding. What's interesting about finerenone is its distribution. It seems to accumulate about equally in the heart and kidneys.
Unlike spironolactone and epinephrine, which concentrate more in the kidneys.
Right. This more balanced distribution might make finerenone particularly attractive for direct cardioprotective effects. Another key finding is that finerenone seems to cause less hyperkalemia than spironolactone or epinephrine, although the risk is still significant. This might be related to its lower accumulation in the kidney. It also tends to have less effect on blood pressure compared to the older agents. Isaxarenone, available in Japan, seems to have a stronger BP lowering effect.
What about amiloride and triamterene, the ENaC blockers?
Pharmacokinetically, they're different. Amiloride isn't really metabolized, it's excreted unchanged by the kidney. Triamterene, however, is extensively metabolized by the liver, and its metabolites are excreted renally. Triamterene has a shorter half-life.
And that new aldosterone synthase inhibitor, baxdrostat.
Still investigational, but phase 2 results in treatment-resistant hypertension looked promising, showing significant blood pressure reduction. Its diuretic effect isn't fully characterized, but the risk of hyperkalemia appears lower than with MRAs.
Pharmacodynamically, all these agents reduce sodium absorption in the collecting tubules. MRAs block aldosterone's action. ENaC blockers directly stop sodium entry. They also affect acid secretion.
Yes, they inhibit proton secretion by intercalated cells in parallel with inhibiting potassium secretion, which explains why MRAs can sometimes cause a mild metabolic acidosis, similar to type IV renal tubular acidosis. And, like other diuretics, their actions can be influenced by renal prostaglandins, meaning NSAIDs could potentially interfere.
Clinically, where are potassium sparers most useful?
Primarily in states of mineralocorticoid excess, either primary hyperaldosteronism like Conn syndrome or secondary hyperaldosteronism, which you see in heart failure, cirrhosis, nephrotic syndrome situations where aldosterone levels are high, leading to potassium wasting. They're excellent for blunting that K+ loss.
And crucially for counteracting potassium wasting from other diuretics.
Absolutely. They are frequently combined with thiazides or loop diuretics specifically to prevent or treat hypokalemia, especially when diet and KCl supplements aren't enough.
What about the cardioprotective effects of MRAs?
That's a major indication now. Low doses of epinephrine or spironolactone interfere with the harmful fibrotic and inflammatory effects of aldosterone on the heart and blood vessels. They slow progression of albuminuria and diabetes, improve outcomes after MI. The RALIS trial was a landmark study showing mortality benefit with spironolactone in severe heart failure. Ephesus showed benefit with epinephrine post-MI.
And potential role in atrial fibrillation.
Some evidence suggests MRAs might reduce AFib recurrence after ablation, spironolactone, or risk in CKD diabetes, finerenone. Seems like a class effect.
Other specific uses. Amiloride in Little syndrome.
Yes, Little syndrome involves hyperactive ENaC channels, so amiloride, which blocks ENaC, is the specific treatment. Spironolactone isn't effective because aldosterone isn't the problem. Amiloride is also uniquely useful for lithium-induced nephrogenic diabetes insipidus.
And spironolactone's non-renal uses.
Used off-label for acne and female pattern hair loss due to its anti-androgen effects. Modest benefit. Also an interesting finding associating it with reduced prostate cancer risk in men treated for heart failure.
Okay, toxicity. The big one here is the opposite of other diuretics. Hypercalemia.
The cardinal risk. Because they reduce urinary potassium excretion, they can cause mild, moderate, or even life-threatening hyperkalemia.
When is the risk highest?
The risk is dramatically increased by underlying renal disease or by concomitant use of drugs that suppress the renin-angiotensin system, beta blockers, NSAIDs, ACE inhibitors, ARBs, eliskerin. Using them alone, especially in renal insufficiency, is particularly risky.
Combinations with thiazides are safer regarding potassium.
They balance out the potassium effects, yes, But fixed-dose combinations aren't ideal as individual dosing is often needed, and that Raylis trial, while showing benefit, also led to increased hypercalcaemia admissions and deaths when applied broadly without careful patient selection and monitoring post-publication. It highlights the absolute need for extreme caution and close potassium monitoring, especially in renal insufficiency or with interacting drugs.
What about acidosis?
Hyperchloremic metabolic acidosis can occur, as mentioned, due to inhibition of H+ secretion.
And those endocrine effects with spironolactone.
Gynecomastia, impotence, menstrual irregularities due to its binding to androgen and progesterone receptors. These are not typically seen with the more selective eplerenone or finerino.
Oh, there are toxicities.
Acute renal failure has been reported with the combination of triamterene and indomethacin, an NSAID. Triamterene itself is poorly soluble and can precipitate in the urine, forming kidney stones.
Contraindications.
The main one is conditions predisposing to hyperkalemia, especially chronic renal insufficiency. These patients should rarely receive potassium-sparing diuretics. Oral potassium supplements must be stopped. Concomitant use with multiple RAS blockers is extremely risky. Liver disease can impair metabolism of triamterene and spironolactone. And strong CYP3A4 inhibitors like ketoconazole, clarithromycin, grapefruit juice can significantly increase eplerenone levels, requiring dose adjustment or avoidance.
All right, let's move to the agents that primarily alter water excretion, the diuretics, starting with osmotic diuretics.
Mannitol is the prototype here. These are substances that are freely filtered at the glomerulus but are poorly reabsorbed by the renal tubules. They stay in the tubule lumen.
And act like osmotic sponges.
Exactly. By increasing the solute concentration within the tubule, they osmotically hold water in the lumen, preventing its reabsorption, especially in the segments freely permeable to water like the PCT and the descending limb of Henle's loop. They also oppose ADH's action in the collecting tubule.
The net effect is increased urine volume.
Yes, a significant increase. But importantly, the resulting natriuresis, sodium excretion, is usually less than the water diuresis. This means they can actually lead to hypernatremia and dehydration if fluid intake doesn't keep up. Uncontrolled diabetes with high glucose in the urine also causes an osmotic diuresis, but glucose isn't used therapeutically for this.
Pharmacokinetically, mannitol isn't given orally.
No, it's poorly absorbed and would just cause osmotic diarrhea. It must be given intravenously for systemic effects. It's not metabolized and is excreted primarily by glomerular filtration within about 30-60 minutes. Critical point, use with extreme caution in renal insufficiency, because if it can't be excreted, it accumulates and causes major problems.
Clinically, what's their main use?
Their primary and most important indication is to reduce intracranial pressure, like in cerebral edema, and intraocular pressure before eye surgery or in acute glaucoma. By increasing the osmolarity of the blood, they pull water out of brain cells and eye tissues, reducing intracellular volume and pressure.
Any other uses?
Some nephrologists use it empirically, trying to prevent reactions when initiating hemodialysis, but evidence is limited.
What about toxicities? Initial volume expansion.
Yes, before the diuresis starts, mannitol pulls water out of cells and into the extracellular space. This initially expands the ECF volume and can cause hyponatremia. This can be dangerous in heart failure, potentially causing pulmonary edema. Headache, nausea, vomiting are common.
And later on.
If used excessively without adequate water replacement, it leads to profound dehydration, free water loss, and hypernatremia. As water leaves cells, intracellular potassium gets concentrated, leading to potassium leaking out of cells and potential hyperkalemia.
And if the patient has severe kidney impairment,
then the mannitol can't be excreted. It gets trapped in the bloodstream, causing ongoing osmotic extraction of water from cells, leading to hyponatremia, but without the expected decrease in overall serum osmolality, because the mannitol itself is contributing to the osmolality. Acute kidney injury is also a well-described risk, likely due to the high osmolality.
Okay, next category of diuretics. Antidiuretic hormone, ADH, antagonists, the vaptins. Used when water retention is driven by too much ADH.
Exactly. Situations like SIADH, syndrome of inappropriate ADH secretion, or sometimes in advanced heart failure or cirrhosis where ADH levels are pathologically elevated, leading to water retention and often hyponatremia.
Historically, other drugs were used for this.
Yes. Older, non-selective agents like lithium and dimeclocycline, an antibiotic, were found to interfere with ADH action in the collecting duct. They were used for chronic SIADH, but they have significant side effects and less specific mechanisms. They've largely been replaced by the vaptins.
Which target specific vasopressin receptors.
Right. There are V1A and V1B receptors, mostly in blood vessels and CNS, and V2 receptors, kidney-specific, mediating ADH's effect on water reabsorption. Conivaptan is an IV agent that blocks both V1A and V2 receptors. Tolvaptan is an oral V2 selective antagonist that's FDA approved. Lixivaptan, Satavaptan are others that have been studied.
How do they work pharmacodynamically?
They directly block ADH from binding to its V2 receptors on the collecting duct cells. This prevents the insertion of AQP2 water channels into the apical membrane, rendering the tubule impermeable to water and leading to excretion of dilute urine, aquaresis. Lithium and dimeclocycline interfere with the signaling pathway downstream of the receptor.
Clinical indications. SIADH.
Yes, for SIADH, when water restriction alone isn't enough or isn't tolerated. Dimeclocycline or tolvaptan can be used orally. Conivaptan is 5e only for hospitalized patients.
What about heart failure or other causes of high ADH?
They are used here too, particularly for hyponatremia associated with these conditions. Conivaptan might offer an advantage in acute heart failure because blocking V1A receptors can cause vasodilation, reducing afterload, and potentially increasing cardiac output. Tolvaptan, added to standard diuretics in heart failure, effectively raises serum sodium, increases urine output, and decreases body weight, often without worsening serum creatinine, a key potential benefit. Also used for fluid overload hyponatremia in pediatric nephrotic syndrome.
And the big one, autosomal dominant polycystic kidney disease, ADPKD.
Yes, this has become a major indication for tolvaptan. Cyst growth in ADPKD is driven by CAMP signaling, and ADH vasopressin is a major stimulator of CAMP in kidney cells. The hypothesis was that blocking V2 receptors would slow cyst growth.
And did it work?
Large clinical trials showed that tolvaptan significantly slowed the increase in kidney volume and the rate of decline in kidney function over several years compared to placebo. It's a major therapeutic advance for ADPKD.
But there was a safety concern.
Yes, a significant one. In the high doses used for ADPKD, there was about a 9% incidence of significant liver enzyme elevations, sometimes leading to drug discontinuation. This requires careful liver function monitoring. Importantly, this hepatotoxicity hasn't generally been seen with the lower doses used for treating hyponatremia.
Other toxicities. Risk of going too far the other way.
Absolutely. The main risk is overshooting, causing excessive water loss, leading to hypernatremia and symptoms of nephrogenic diabetes insipidus, polyuria, polydipsia. Serum sodium must be monitored very closely, especially when starting therapy or adjusting doses. Patients must be able to drink water in response to thirst.
Other issues.
Dry mouth and thirst are very common. Tolvaptan can sometimes cause hypotension. Lithium, of course, has many other toxicities. Dimeclocycline is avoided in liver disease in young children. Regarding tolvaptan and the liver, while contraindicated in active hepatitis, there's nuance. It has been used successfully in patients with stable, decompensated cirrhosis to manage refractory ascites or hyponatremia, reducing the need for albumin and diuretics. Requires careful patient selection and monitoring.
And finally, the investigational diuretics.
Right, these target urea transporters, UTA, UTB. The idea is to promote excretion of urea and the water that follows it without affecting electrolytes like sodium. Preclinical agents like PU14 show promise. They act as aquaretics, blunt the kidney's response to ADH regarding urine concentration. Their potential clinical role versus vaptins in edema or SIADH is still being explored, a novel mechanism.
Okay, we've covered the individual tools. Now let's talk about the power of combination therapy, starting with the classic pairing. Loop agents and thiazides, often used for refractory edema.
Exactly. Some patients just don't respond well, even to maximal doses of loop diuretics alone. This can happen for various reasons, including the loop's short half-life, allowing the kidney to avidly retain sodium during the drug-free intervals, or downstream compensatory hypertrophy. Continuous loop infusions have shown mixed results, but might help some patients.
But adding a thiazide can produce dramatic results.
Dramatic synergy is the key word. The effect is often far greater than just additive, especially when neither drug works well on its own. It can unlock very resistant edema.
Why such powerful synergy? What's the mechanism?
Two main reasons. First, blocking compensatory reabsorption. If you block salt uptake in the tail with a loop, the DCT downstream tries to pick up the slack. By adding a thiazide to block the DCT as well, you shut down that compensation. Second, thiazides have a mild inhibitory effect on salt reabsorption way back in the PCT, which is usually masked by increased uptake in the tail. When you add a loop diuretic to block the tail, that proximal effect of the thiazide might become unmasked. So you end up inhibiting salt reabsorption significantly in potentially 3 different segments.
Which thiazide is usually used for this?
Metolazone is often the go-to thiazide-like drug for this combination, partly due to historical use and its reputation for efficacy even at lower GFRs, though other thiazides at equivalent doses likely work too. Chlorothiazide is the IV option if needed.
What are the cautions? This sounds potent.
Extremely potent, and that's the main caution. This combination can mobilize massive amounts of fluid very rapidly. It absolutely requires close hemodynamic monitoring, ideally initiated in an inpatient setting. Routine outpatient initiation is generally not recommended without extreme caution and very frequent follow-up.
And potassium.
Profound potassium wasting is extremely common and can be severe, often requiring large doses of potassium replacement, sometimes intravenously, along with careful electrolyte monitoring. The ongoing chlorotic trial is formally studying this combination. For outpatient management, a strategy might be infrequent, low-dose thiazide add-on, G-metolazone 2.5 milligrams once or twice a week initially, with very close BP and potassium monitoring.
This brings us right back to our opening case study, that patient's AKI and dramatic weight loss.
Almost certainly resulted from this powerful, potentially dangerous synergy. The addition of hydrochlorothiazide to his chronic high-dose furosemide, especially given his pre-existing chronic kidney disease, led to excessive volume depletion and likely prerenal azotemia, tipping him into acute kidney injury. It underscores the absolute need for caution and monitoring.
A critical lesson. Now, what about combining potassium-sparing diuretics with other diuretics?
The main purpose here is simply to balance potassium. Hypokalemia is a frequent headache with CAIs, loops, and thiazides. When dietary changes or potassium supplements aren't enough or aren't tolerated, adding a potassium-sparing diuretic like spironolactone, eplerenone, or remolaride can significantly reduce potassium excretion and help maintain normal levels.
Is this combination generally safe?
Generally safe if used appropriately. The major caveat, as we discussed, is the risk of hypercalemia. This combination should be avoided or used with extreme caution in patients with significant renal insufficiency, and especially those also taking ACE inhibitors, ARBs, or other drugs that raise potassium. In those settings, life-threatening hyperkalemia can develop rapidly.
From a pure diuretic standpoint, is adding a potassium sparer as effective as adding a thiazide to a loop?
For sheer volume removal, adding a thiazide to a loop diuretic generally seems to produce a more potent diuretic effect than adding spironolactone or another potassium sparer to a loop agent.
Okay, we've got the mechanisms, the drugs, the combinations. Let's put it all into practice. Clinical applications and specific scenarios, starting with general oedematous states.
Edema, or swelling, often results when diseases, cardiac, renal, vascular, reduce effective blood flow to the kidney. The kidney interprets this as volume depletion and responds by retaining salt and water, expanding the extracellular fluid volume.
Diuretics help mobilize this excess fluid.
Yes, judicious use aims to mobilize that interstitial edema fluid without drastically shrinking the plasma volume. It's a fine balance. Excessively rapid diuresis can actually compromise arterial blood volume and reduce organ perfusion. Careful monitoring is key.
What about heart failure specifically? Diuretics are essential here.
Absolutely fundamental. In heart failure, the weakened heart's reduced output triggers that renal salt and water retention. Initially, this helps maintain cardiac output via the Frank-Starling mechanism, but eventually it leads to volume overload, pulmonary congestion, and peripheral edema.
So diuretics reduce the congestion.
Exactly. They reduce preload, the volume stretching the heart before contraction, which alleviates symptoms like shortness of breath, improves oxygenation, and can actually improve myocardial function by moving the heart to a more favorable part of its performance curve. Loop diuretics are the mainstay. Combinations with thiazides are used for severe refractory volume overload.
But there are dangers in over-diuresing heart failure patients.
Big dangers. Cardiac output in advanced heart failure is often highly dependent on adequate filling pressures. If you pull off too much fluid too quickly, you can drop preload too far, reducing stroke volume and cardiac output, potentially worsening organ perfusion, especially critical in right heart failure. It can also worsen renal function by reducing kidney perfusion.
What about specific toxicities in heart failure?
Alkalosis.
Potassium.
Metabolic alkalosis, often worsened by hypokalemia, can impair cardiac function and increase arrhythmia risk. It's treated with potassium replacement. If fluid status allows, small amounts of saline can help correct the alkalosis. If not, acetazolamide or adding a potassium-sparing diuretic are options. Hypokalemia itself is dangerous, increasing the risk of arrhythmias and digitalis toxicity. Prevention with low-sodium diet, oral KCl, or potassium-sparing diuretics is crucial.
And the role of vaptins in heart failure.
Still evolving. They are used for treating significant hyponatremia in heart failure. There's interest in whether they can manage volume overload with less electrolyte disturbance than high-dose loops. Some studies suggest short-term benefits like reduced worsening renal function, but long-term outcome data is less definitive.
Let's move to kidney disease and renal failure. Most kidney diseases cause salt and water retention, right?
Yes. However, diuretics have limited benefit once GFR drops below about 5 mL/N. But importantly, many patients with milder severe renal insufficiency, GFR 5 to 15 LMN, even those on dialysis, can still respond to and benefit from diuretics.
Benefits even on dialysis.
Some, albeit low-quality evidence, suggests continuing diuretics in end-stage kidney disease might reduce hospitalizations, blood pressure drops during dialysis, and fluid gains between sessions. In acute renal failure, diuretics can help manage fluid balance short-term, but don't alter the underlying course or improve long-term outcomes. Glomerular diseases often cause significant saltwater retention, and diuretics are very effective for the resulting edema and hypertension.
What about hypercalemia in kidney disease?
Common problem, especially in diabetic nephropathy or type IV RTA. Thiazides, or loop diuretics, can actually be used therapeutically here to increase potassium excretion by boosting salt delivery to the collecting duct.
Nephrotic syndrome seems particularly complex.
It is. Some patients, especially those with minimal change disease, might have massive edema but actually be intravascularly volume depleted. Diuresing them aggressively can worsen GFR and cause hypotension. Other forms involve primary salt retention and volume expansion, where diuretics are clearly beneficial. Vaptin use here is still under investigation.
Are there limitations on which diuretics to use in kidney disease?
Definitely. Acetazolamide is usually avoided, worsens acidosis. Potassium-sparing diuretics carry a high risk of hypercalcaemia. Thiazides were traditionally thought ineffective below GFR 30, but this is being challenged. They can potentiate loop diuretics even at much lower GFRs, down to 515 millimins. High-dose loop diuretics, like furosemide up to 500 milligrams a day, or loop metalozone combinations are often needed in advanced CKD or dialysis. But always remember, excessive diuresis can significantly worsen underlying kidney function.
Now, hepatic cirrhosis, another very delicate balancing act.
Extremely delicate. Cirrhosis leads to ascites and edema due to complex factors. High portal pressure, low albumin, reduced kidney perfusion signaling salt retention, and very high aldosterone levels. Diuretic therapy is needed for significant fluid overload.
Are loop diuretics effective?
Often resistant. Decreased delivery to the kidney tubule and the high aldosterone levels counteract their effect. But patients with cirrhosis are often unusually responsive to the MRAs spironolactone and eplerenone because they directly block that high aldosterone effect. A combination of an MRA plus a loop diuretic is frequently the best approach.
Caution level here. Maximum.
Maximum caution. Overly aggressive diuresis is potentially catastrophic. It can lead to severe intravascular volume depletion, hypokalemia, metabolic alkalosis, and precipitate life-threatening hepatorenal syndrome or hepatic encephalopathy. Slow and steady is the rule.
What about vaptins in cirrhosis?
Relatively contraindicated if there's active liver inflammation due to the hepatotoxicity risk seen with high-dose tolvaptan. However, in patients with stable end-stage cirrhosis without active hepatitis, low-dose tolvaptan has been used cautiously and successfully to manage refractory sites or hyponatremia, potentially reducing the need for albumin infusions. Requires expert judgment.
What about idiopathic edema, that fluctuating swelling in young women?
Pathophysiology is really unclear. It's a diagnosis of exclusion, an important point for clinicians. You have to consider if the patient might be surreptitiously using diuretics intermittently, as this can actually perpetuate the cycle. Management is tough. Spironolactone has been tried. Often, the best approach is moderate salt restriction and perhaps compression stockings, avoiding diuretics if possible.
Okay, shifting to non-edematous states. First, the huge one, hypertension.
Thiazides are cornerstone first-line agents. Their diuretic and mild vasodilator effects are highly effective for essential hypertension. Chlorthalidone, with its longer half-life, might offer better 24-hour BP control but potentially more side effects. Major trials like ALL-HAT confirmed that inexpensive thiazides provide outcomes similar or even superior to newer, more expensive classes like ACE inhibitors or calcium channel blockers for preventing major cardiovascular events.
When are loops used for hypertension?
Generally reserved for patients with significant renal insufficiency, GFR 30-40 millim, or concomitant heart failure, where thiazides become less effective as diuretics.
What enhances diuretic effectiveness in hypertension?
Moderate dietary sodium restriction, it potentiates the BP lowering and lessens potassium wasting. Adding potassium-sparing diuretics can also mitigate potassium loss. Chlorthalidone has shown efficacy even in stage 4 CKD.
And diuretics are key in combination therapy.
Yes, they enhance the efficacy of many other antihypertensives, especially ACE inhibitors and ARBs. They are essentially required when using potent direct vasodilators like hydrolazine or minoxidil, which cause significant reflex salt and water retention. And interestingly, spironolactone is emerging as perhaps the most effective add-on agent for truly resistant hypertension, even in dialysis patients.
Next, non-oedematous use, nephrolithiasis or kidney stones.
About 2/3 of stones contain calcium. Many patients who form calcium stones have a defect leading to excess calcium excretion, hypercalciuria.
How do thiazides help?
By enhancing calcium reabsorption in the DCT, they reduce urinary calcium concentration, directly lowering the risk of calcium stone formation. Key counseling points: increase fluid intake, but reduce dietary salt. Excess salt overwhelms the thiazide's calcium-lowering effect. And importantly, do not restrict dietary calcium, as that can actually worsen bone health and potentially stone risk.
What about hypercalcaemia, a potential emergency?
Loop diuretics are used here because they significantly reduce calcium reabsorption, promoting calcium excretion.
But there's a crucial caveat.
Absolutely critical.
Yeah.
Loop diuretics alone will cause volume contraction, which shuts down the GFR and makes them ineffective for calciuresis. You must administer intravenous saline simultaneously with the loop diuretic, like furosemide 80 to 120 milligram IV, to maintain volume status and drive the calcium excretion. Match saline infusion rate to urine output.
Okay. Diabetes insipidus, DI, excessive thirst and urination.
2 types: central DI, lack of ADH, and nephrogenic DI. NDI kidneys don't respond to ADH. Thiazide diuretics have a paradoxical effect in NDI.
They reduce urine output in NDI.
Yes, they reduce the polyuria and polydipsia in NDI. The mechanism involves inducing mild volume depletion, which enhances proximal tubule fluid reabsorption, reducing fluid delivery to the collecting duct. There may also be direct effects on collecting duct function. Dietary sodium restriction is essential to potentiate the effect.
Particularly useful for lithium-induced NDI.
Yes, a common cause of NDI. Thiazides work well, but caution. Thiazides reduce renal lithium clearance, so lithium levels must be monitored closely to avoid toxicity. Amiloride is another option for lithium-induced NDI, as it can block lithium entry into collecting duct cells via the ENIC channel. Acetazolamide has also shown some efficacy.
Finally, the broader roles in renal and cardiac protection, going beyond just fluid removal.
Aldosterone antagonists, MRAs, are clearly cardioprotective, reducing mortality and morbidity in heart failure and post-MI. They also show promise in reducing albuminuria in diabetic kidney disease. Hypercalcaemia remains the main limiting factor, especially in CKD. But studies like Top Hat Americas and trials with finer-known, Fidelio-DKD, Figaro-DKD, show significant renal and cardiovascular benefits even in CKD patients, albeit with careful monitoring for hyperkalemia.
Finerenone seems particularly promising for kidney disease.
Yes, it demonstrated clear reductions in CKD progression and cardiovascular events in large trials of patients with type 2 diabetes and CKD, with a lower incidence of severe hyperkalemia compared to spironolactone.
What about amiloride trimterene?
They've also shown ability to reduce proteinuria and blood pressure in proteinuric kidney disease, but hyperkalemia is a concern. And of course, the SGLT2 inhibitors are now firmly established as both cardio and renoprotective across a wide spectrum of patients.
And lastly, let's just revisit that nuance about the risk of hyponatremia with different classes. It's not what you might intuitively think.
It really isn't. That large Scandinavian study was eye-opening. It found loop diuretics were associated with a lower risk of hyponatremia. Odds ratio 0.61, possibly even protective. In contrast, amiloride and spironolactone had increased risk, and thiazides are generally considered to carry the highest risk. It really highlights the need for precise understanding of each class's effect on water handling.
Wow, we have covered an immense amount of ground. We've journeyed from the microscopic transporters in the nephron right through to complex clinical scenarios. We've dissected the mechanisms of each diuretic class, their pharmacokinetics, their uses, and importantly, their potential dangers. You should now have a truly deep, professional-level understanding of these powerful agents.
Absolutely. You've seen how these drugs interact with the kidney's intricate machinery, how blocking one transporter here or modulating a hormone there can have profound cascading effects on fluid balance, electrolytes, blood pressure, and even long-term organ health.
Think back to that initial case study. With the knowledge we've unpacked today, you can pinpoint exactly why adding that thiazide to the loop diuretic in that specific patient with CKD led to such a dramatic and dangerous outcome. It underscores the vital importance of understanding synergy, patient factors, and meticulous monitoring.
The body's ability to maintain fluid and electrolyte homeostasis is truly remarkable. Diuretics are powerful tools that allow us to intervene when that balance is disrupted, but they demand respect and deep understanding. Their precise use is key to harnessing their benefits safely and effectively.
It leaves you wondering, doesn't it? What's next? Well, newer approaches like those diuretics perhaps offer even more targeted ways to manage fluid disorders with fewer side effects.
Yeah.
And on a personal level, how does appreciating this delicate internal balance influence how you think about your own hydration and health choices day to day?
Keep exploring these questions. Keep learning. The kidney is an endlessly fascinating organ. Share what you've learned today with others who share that curiosity about the amazing complexities of the human body.